Welcome to oral anti-diabetic agents. Oral hypoglycemic agents work by stimulating pancreatic beta cells to release insulin into the bloodstream, decreasing glucose production in the liver, gluconeogenesis, and changing glycogen to glucose. They also work by increasing the number of insulin receptors in tissues to provide more opportunities for cells to bind with insulin-enhancing glucose uptake by peripheral tissues and by reducing insulin resistance. Additionally, oral hypoglycemic agents delay carbohydrate absorption in the small intestine, in the stomach. Oral anti-hypoglycemic agents are only effective in type 2 diabetes. They're only effective in clients whose blood sugar is controlled with an oral med, and they may need insulin in times of stress, infection, or surgery. Also, you may continue to need insulin even after the event has passed due to progressive B-cell destruction. Oral anti-diabetic agents are started at the lowest effective dose and are increased every 1 to 2 weeks until the patient reaches the desired blood sugar control. Selection of the specific medication is based on its cost, its ability to manage multiple drugs, age, and response to the particular drug. Oral therapy for type 2 diabetes includes several sites of action, including the stomach, the pancreas, the liver, the muscle, and adipose tissue. Certain medications work in certain areas, and oftentimes a combination of medications helps to effectively manage the patients. The classifications of oral anti-diabetic agents include the sulfonylureas, which stimulate the pancreas to release more insulin and increase the number of sensitivity of cell sites to insulin. Common medications in this category include glucotrol, diabeta, and Amaryl. Possible side effects of these medications include hypoglycemia and weight gain, and the client can't use the medication if they're allergic to sulfa drugs such as Bactrim. They need to take it with meals, and it's not recommended with a patient with hepatic or renal impairment. Most often before these medications are prescribed, doctors will most often order liver function tests and a creatinine to understand if the patient has acceptable lab parameters to prescribe the medication. The meglitinides stimulate the pancreas to produce insulin, and this group of medications, Prandin and Starlix, are two of them. Possible side effects of these medications are hypoglycemia, weight gain, and liver failure, and you need to be giving these medications 30 minutes before a meal so their activity is already working when the patient eats. The biguanides suppress liver gluconeogenesis, and they increase sensitivity to insulin without causing hypoglycemia in the patient. A common type of biguanide is metformin, or Fortamed. Possible side effects of these two drugs are nausea, vomiting, and diarrhea, a metallic taste in the mouth, weight loss, and a reduction in blood lipid levels. Biguanides have several precautions, including you need to take them with food. They must be held for 48 hours before a CT scan with IV contrast, and they're not to be used in a patient with renal insufficiency, liver disease, or documented congestive heart failure. The thiazolinodiones, or the TZDs, increase insulin sensitivity in the peripheral tissues, and they also reduce liver glucose production. Medications such as these are Actos and Avandia. Possible side effects of these medications are weight gain and edema, possible mild anemia, and an increased risk for MI or stroke. Precautions with the TZDs include not to use them with liver disease or documented congestive heart failure, and oftentimes it's 4 to 6 weeks before the full effect of the medication is appreciated. The alpha-glucosidase inhibitors delay glucose absorption in the small intestine. These medications include Precoce or Glycet. Possible side effects of these two medications are bloating, flatulence, and diarrhea, and oftentimes they're very rarely used due to severe side effects. The DPP-4 inhibitors enhance insulin secretion in response to food intake. They slow gastric emptying, and they decrease hepatic glucose output. Two of these medications that are DPP-4 inhibitors are Januvia and Onglyza. Possible side effects of these two medications are headache, sore throat, nausea, and diarrhea, and the provider needs to remember to decrease the dose in renal impairment. Subcutaneous antidiabetic drugs often known as the insulin pen. Incretin mimetic, or the insulin pen, stimulates release of insulin, decreases glucagon secretion, and decreases gastric emptying. Two common ones of these are exenatide or liraglutide. Possible side effects of these medications are nausea, vomiting, hypoglycemia, diarrhea, and headache. Precautions include acute pancreatitis and kidney problems that have been associated with the drug. One of the superior things about the insulin pen is the ease of administration and the ability for the client to be more compliant because they don't have to draw up insulin. Additionally, this is also valuable in elderly patients who have a hard time seeing the insulin syringe. Insulins. There are several different types of insulins, and all of them vary in their onset, their peak, and duration. There's the ultra rapid acting insulins, the rapid acting insulins, the intermediate acting insulins, and the long acting insulins. The ultra rapid acting insulin is the two kinds are Novolog and Humalog. Their onset is 15 to 30 minutes, their peak is 1 to 3 hours, and their duration is 3 to 5 hours. Ultra rapid acting insulins need to be given immediately before a meal because their onset is very rapid. Additionally, every time with insulin or any type of oral anti-diabetic agent, it's imperative that you understand if the client is going to eat well or not, because lack of food in the body, along with insulin or oral anti-diabetic agents, can result in a profound hypoglycemic reaction. Rapid-acting insulins are regular, semi-lente, which isn't prescribed very often anymore, or a combination of rapid and intermediate-acting 70-30. 70-30 has most of its insulin as regular and the other 30 as NPH. Therefore, its onset is going to be much more on the rapid-acting side. Intermediate insulin are NPHs, are Humulin N, and are lente. The onset of these is 1 to 2 hours, the peak is 6 to 12, and the duration is 16 to 24 hours. And then the long-acting insulins, the ultralente, the Humulin U, and the Lantus. And if you notice, the ultralente and the Humulin U have a peak in duration, whereas Lantus provides a steady stream of insulin delivery for a period of 24 hours. Lantus is becoming the gold standard for diabetic medications as it's a basal dose of insulin for most patients and helps to avoid the peaks and valleys that come across when using long-acting insulins that have a peak and a duration. Insulin facts. Lantus is the only type of insulin that cannot be mixed with other types of insulin. Other types of insulins are mixed clear to cloudy or rapid and short-acting followed by the intermediate. Regular or Humulin R and Novolog or Humalog insulins are the only types that can be administered IV. All others are administered subcutaneously. The pancreas produces a constant basal amount of insulin in normal people that maintains normal blood glucose levels between meals. The basal insulin in most diabetics is now covered usually by NPH or Lantus. For the most part, Lantus is superior for doing this. The pancreas also produces additional insulin to prevent blood sugar elevation after meals, your prandial. And this is where your bolus doses or your subcutaneous injections are usually given after meals. The prandial insulin is covered by the rapid and short-acting insulins, and the basal insulin is covered by the Lantus or the NPH. Remember, in patients, it's always important to check blood sugars when patients are symptomatic for whatever reason, if they have periods of illness, before and after exercise, if there's a suspected gastroparesis, with adjustments in diabetic medications, and for the evaluation of the effect of other drug therapies, such as steroids, on blood sugar. Absorption of insulin is fastest in the abdomen, and it's the most preferred site, followed by the back of the arms, the outer thighs, and the buttocks. Most hospitals prefer that nurses use the back of the arms for patients when they're in the hospital because that's two areas where the patient really can't inject themselves readily and most often does not get used. Rotate injection sites to prevent lipohypertrophy, which is an increase in the swelling of fat, or lipoatrophy, which is a loss of fat tissue. Factors that increase blood flow to injection sites of insulin and increase the absorption of insulin are exercise, local heat application, intramuscular injections of insulin. And factors that decrease blood flow and therefore decrease the absorption of insulin are scar tissue, scars, and tattoos. Dawn phenomenon. Dawn phenomenon is an increase of blood sugar around 4 to 6 a.m. that's thought to be brought about by the increased secretion of counter-regulatory hormones such as glucagon, cortisol, epinephrine, and growth hormone. If dawn phenomenon happens in your patient, then it's important to make sure you're treating this phenomenon by increasing insulin or changing the timing of the insulin to accommodate for the dawn phenomenon that happens in certain people. Certain people's counter-regulatory mechanisms are more efficient than others, so this doesn't happen in every patient. And the incidence of prescribing Lantus insulin has really helped to reduce the amount of dawn phenomenon. Smog-Y phenomenon is a rebound effect in which an overdose of insulin induces hypoglycemia around 2 to 4 a.m. Patients who overshoot their insulin needs may find this happening. Increase of blood sugar around 6 to 8 a.m. is due to the increase of counter-regulatory hormones in this process. You need to treat it with decreasing insulin, and they may need to check blood sugars between 2 and 4 a.m. to accommodate for this problem.